And then at the end, we're just going to talk about how we can move forward as a support group, what you want from a support group, i.e. venues, speakers, and things like that, really. All right, so we'll start. This is Dr Nayar. He's a consultant diabetologist and endocrinologist, and he's also the lead for Diabetes at Sunderland Hospital. So I'll hand over.
Thank you very much, sir. Too kind. My name is Rahul Nayar. I'm just one of the other diabetes consultants working at City Hospitals Sunderland. I'd just like to thank Joe and yourselves and the Diabetes UK support group really for inviting me. It's a real honour really to talk to you all. I recognise a few faces, which is always comforting to know in an environment like this. And my role really is, I see this is being filmed, so I best pay attention. I didn't realise, I thought it was just going to be the slides. Luckily, it's put me off now, hasn't it? But anyway, as I say, I'm just one of the diabetologists working at City Hospitals Sunderland, and I'll probably just talk to you about things you already know about diabetes. And I'm going to focus both on type 1 and type 2 diabetes, and I'm perhaps just going to set the agenda about why I think diabetes is a really, really serious condition. It's really important, and I'm probably telling you things that you already know about diabetes, but I feel it's our duty to pass on that information to others who may not have the opportunity either to engage with people like Joe, yourselves, or kind of medical services, or just decided that at the moment in time, it's not their time to kind of address their diabetes concerns. And part of that really is that diabetes has been in the news quite a lot, sometimes for the good reasons, as in the work that yourselves are all doing and Diabetes UK do, and just a bit of blatant advertising about the charitable association between Diabetes UK, Tesco's and the British Heart Foundation. So there's plans afoot to try and get a lot related to diabetes care out there in the community so people understand what diabetes is about. As I say, some good things about diabetes is all the charitable work that Diabetes UK do to raise the awareness about type 1 diabetes and the treatments and the new cutting-edge therapies and technologies that are available, and also in terms of health promotion for people with type 2 diabetes or what they call pre-diabetes or borderline diabetes, so that they can empower themselves and understand what the condition means and how making changes in their lifestyle can help with not only themselves but their families and their extended families and friends to reduce their risk of diabetes. So here are a few kind of snapshots really about what diabetes been in the news. We know that diabetes, the increasing prevalence or the numbers of people with diabetes in the UK is steadily rising and rising, and that's for predominantly people with type 2 diabetes, but also to some degree with people with type 1 diabetes. And we know that the treatments, although are changing, more and more people are moving on to insulin, particularly with type 2 diabetes. And unfortunately, there can be a number of errors and concerns related to diabetes care. Not all healthcare professionals understand or truly respect what all the aspects of diabetes involves, and that certainly for the newspapers just the other day there was quite a frightening report in a hospital in Stepping Hill in Manchester, where the use of insulin led to unfortunate deaths, and this was a criminal offence, and thankfully that individual was caught and sentenced. But it can be a very serious problem, and certainly going into hospital can be a very frightening process, whether it's as an emergency or whether it's as an elective for some sort of procedure or operation. And you want to know that the people looking after you are knowledgeable and you're competent, and that's something that people like myself are always banging the drum about to make sure things have gone well. So I'm just double checking, can people at the back hear me?
Yes.
That's all right then, I can. And so that's my little preamble. And please feel free to ask any questions or wave if you don't hear me, etc., and I'll wave back. when I asked Jo, and thank Jo for inviting me to come along today, and I said, well, what aspects would you like me to talk about? And the primary focus really was about complications related to diabetes. And this is not, although I'm going to talk about the complications, this is not designed to be a scare tactic, because I think fear is a poor motivator when it comes to helping people understand about diabetes, to understand that what we're here trying to do is to help recognize at a very early stage any of the complications related to diabetes. So there's plenty that we can do to intervene, to help, and to prevent that complication progressing, or if we're lucky enough, help that complication reverse back to normal. And part of that involved in all the screening process that you have when you have your eyes checked and your feet checked, and also something that Diabetes UK promote is the 9 key care processes. So that's something that we're going to talk about later on. So the various aspects of this. So a little bit of background, so let's keep it local. In Sunderland, there's approximately 15,000 people with diabetes. About 10% of those have type 1 diabetes, and the other 90% or thereabouts have type 2 diabetes. And there are similarities when it comes to type 1 and type 2 diabetes, but there are obviously important differences. And if it's not too rude, is there a show of hands for people with type 1 diabetes? And show of hands for people with type 2 diabetes? Okay. So this bears out in terms of a quick straw poll of the differences between people with type 1 and type 2. But they're equally important. They are equally important to the individual, and they're equally important to me as a doctor, and certainly as to Jo as a practice nurse and specialist within diabetes, to make sure that we address all the issues that people have. And one of the kind of NHS's concerns is that there are about 7 million people out there in the whole of the UK that are what they call borderline diabetic, or at risk, increased risk of developing diabetes over the next 5 years, which is quite a significant number. And overall, we have about 3 million people in the UK with diabetes. And when I started off in diabetes about 25 years ago, that was only bordering around 1.5 million. So things have progressed quite a lot. So I'm not going to be out of a job. A lot of diabetes care that unites people with type 2 and type 1 diabetes is obviously how we assess the control of anyone with diabetes. And that obviously involves, firstly, how people are feeling. Are they getting any symptoms related to high blood glucose levels? Are they feeling more run down, more tired, more thirsty? Are they getting up in the middle of the night to pass water? Are they having increased risk of getting infections, which leads to a deterioration in their health, and also a deterioration on day-to-day quality of life? So it's really important that we address, by whatever means necessary, either that's a healthy eating plan, exercise and regular activity, or whether that's with people with type 2 diabetes and treatments with tablets or injections, or people with type 1 diabetes where they have to take multiple injections of insulin. And we try and gauge that in terms of symptoms. We also look at people's blood glucose diaries to make sure on the vast majority of occasions, and I would say about 80% of the time, people are getting their blood glucoses in single figures. So blood glucose levels between 5 and 9, most of the time, and say 80% of the time, would be very useful. And that carries with it a low risk of complications and a higher time where people feel well and aren't prone to complications of diabetes. A final way of assessing blood glucose control is something known as the HbA1c. And this is the long-term test for diabetes care. And a few years ago, it underwent a kind of international transformation where we used to record it as a percentage of how long blood in the glucose in the blood was interacting with red blood cells, and that percentage, a good number, would be about 6.5% for people with type 2 diabetes, and about 7.5% for people with type 1 diabetes, or thereabouts. There's differences in terms of age groups and what we're hoping to try and achieve. And then, as I say, about a few years ago, that underwent a bit of a change, and we moved the goalposts, or changed the language, and we now record it in millimoles per mole, which, in terms of this graph, this is the percentages, going from 6 all the way to 12, and the colour scheme is designed to indicate what's good. So green is good, and as it rotates to pink and red, the higher numbers are bad, and they are more likely to lead to complications. When it comes to HbA1c in terms of millimoles per mole, we've got an equivalent number, so 6% used to equate to 42, 7%, 53, and 8%, 84. So there is a calculation that can be done to compare the two, but it's not designed to confuse people, although unfortunately it did. We've kind of changed the language a wee bit, but this is how we determine good control. A few of the differences between people with type 1 diabetes and those people with type 2 diabetes, and everyone's different, but broadly speaking, type 1 diabetes tends to occur in a younger person, certainly under the age of 40. There tends to be a lack of a family history, so it doesn't tend to run in families, and they classically can produce ketones, which we'll talk about a little bit later on, and they always need insulin to make themselves feel better, and it's primarily because their pancreas as a factory to produce insulin has stopped working quite quickly. Whereas people with type 2 diabetes, this tends to run in families, it tends to be of a slower onset and creeps up on people quite insidiously. And this is the group where it can present with complications quite early on. And it tends to be linked with a higher body mass index, or it's certainly related to obesity. And complications can be present at the point of diagnosis. For the next series of slides, what I'm going to talk about really is the concern that we all have within the UK, the world, and the NHS about the rising kind of proportion of people with obesity and what can be done. And we see a lot of this on the TV about, certainly within the hospital, about bariatric surgery and what that means to an individual and what we can do for ourselves when it comes to a healthy eating plan and lifestyle. And we tend to categorize levels of obesity in terms of risk. And although it's probably difficult to see down the back, we've got classifications of a sort of body mass index. So anyone with a body mass index less than 18 is thought to be underweight. A healthy weight is a body mass index running between 19 and less than 25. And overweight, 25 to 30. Obese is above 30, and very obese is above 40. And by classifying it in this way, it's not to be judgmental in any way, it's also to offer the right treatment for the right person. And it also helps us determine from a medical perspective a relative risk and what else can be done for any one individual. The concern here for people with diabetes is that it becomes harder and harder to treat their condition the larger any one individual is. And also, when I mentioned earlier on that the whole of the UK, it has a big concern regarding weight and weight management. We see here about kind of 6 out of 10 men are overweight, so a body mass index above 25, and 5 out of 10 women are also labelled as such. So quite a significant population concern. And when it comes to expanding on that, no pun intended, I'm sorry, again we've got a quarter of the population at risk of developing diabetes later on. And within the northeast, it is quite a significant concern here. On this chart, what you see is the prevalence of obesity by region. And what I've labelled here is the northeast. And the only group that's worse than us is the northwest. So quite a considerable concern when it comes to both men and women. And as I mentioned, this is going to be a bit of a concern when it goes to moving on into the population statistics. I mentioned earlier on that I started kind of within diabetes care some 20 odd years ago, and the next series of slides just show you the colour changes of weight and weight management and obesity over the last 20 years. And the darker the colour, the greater the incidence of obesity over the UK. So you follow it through and you see that things are getting darker and darker. And here we are, turn of the century, worse and worse. And this is the first time the North East is kind of labelled as being red, and it's worse and worse, all the way to kind of present day. Practically the whole of the country is now at risk of developing obesity-related problems. So there is something that we need to do and address, otherwise there's going to be a major problem when it comes to diabetes management. And now comes the focus really on populations, but also on what we can do as individuals when it comes to diabetes management, specifically for people with type 2 diabetes. In conjunction with Diabetes UK and NHS England, we're going to be rolling out what they call a diabetes prevention programme. And this is strongly supported by Tesco's, and the idea of getting a national kind of food company involved with diabetes management is to promote healthy eating, healthy advice and a healthy lifestyle. And this is pinned mainly from international studies done looking at how we prevent type 2 diabetes in an at-risk population. And what it essentially shows is that over time, across the bottom in years, going out from 0 years to 4 years, we've got up this graph is the number of people developing diabetes. If we do nothing in blue, over 4 years, about 40% of people will develop diabetes. If we give somebody a tablet known as metformin, which a number of people with type 2 diabetes are on, we prevent that and we reduce the risk, but not by much. It drops from 40% down to 30%. But in green, if we just adhere to a healthy eating plan and take 30-minute walks every day, we can reduce the risk down to about 20%. So lifestyle changes are probably the best thing for us when it comes to ourselves as people with diabetes, whether it's type 1 or type 2, but also when it comes to managing a population, and hence the reason why the Department of Health, in conjunction with Diabetes UK and Tesco's, as well as the British Heart Foundation, have said this is certainly the way forward, and over the next couple of years there's going to be a strong programme, or a big programme, that promotes the prevention of diabetes through a healthy lifestyle. And a lot of that is going to be driven by general practice, people like Joe doing NHS checks and screening for people with diabetes, and some of you may already be aware of the NHS checks looking at blood pressure, blood glucose levels and blood cholesterol levels, and a screening programme on a year-to-year basis. And some of you also may be aware that Diabetes UK have a risk calculator where you can plug in your details of how old you are, what your sex is, measure your waist circumference or your body mass index, and it'll give you a risk calculator of what your risk might be for developing diabetes, or that of your family or friends. But what it also shows you is that there is something that you can do. There is something that we can advise you about, something that we can support you with when it comes to a healthy eating plan, reduction in portion size, a reduction in salt content of your food, and how we can lower your blood pressure, reduce your risk of having a heart attack or a stroke, but also reduce the risk of diabetes. So this is something that's going to be rolled out across the country. Durham and Darlington are one of the what they call demonstrator sites when it comes to diabetes prevention, but this is also something that's being endorsed and actively promoted by all employees of the NHS. So they're going to go for people like me first. And Joe.
Yeah, definitely me.
And again, a quick plug for Diabetes UK. Diabetes UK are obviously promoting this amongst their websites. They're promoting this across the advertising, and we'll obviously try and promote this through the support network, through yourselves. And again, another big plug. So as if you didn't know, National Diabetes UK Week, or Diabetes Week, is the 14th to the 20th of June. So end of the advertising now, I think. Is that enough advertising? I think so. Okay. The next series of slides now really do talk about the complications related to diabetes. And I do feel passionate about trying to prevent complications occurring in my patients with diabetes, and also promoting the aspect that it's not doom and gloom, because if somebody has a complication, it can be, with the right treatment, either prevented and reversed, or it can be prevented from getting worse. And essentially, by keeping on with that mantra and empowering, I would say, people like yourselves and all the patients that I come across, and Joe, I'm sure, is exactly the same, is by knowing what you should be achieving for your diabetes control, what resources are already available, and what you should demand from Diabetes UK, what you should demand from your healthcare provider, be that your nurse, your GP, your dietitian, the diabetes specialist nurse, your hospital doctor. You should know that these things are available. And by knowing what the risks are and what's available, similar to the research that we all do, if we're going to buy a cooker or a fridge or something like that, then we know that we want to buy what is best and what we can afford and what's useful for us. By knowing what's out there to help people with diabetes and what the idea is, what we can prevent, is certainly something that somebody should be empowering. So we know that glucose, blood pressure, or high blood pressure and high cholesterol can damage the body for any one of us, and certainly in people with diabetes, it occurs at a faster rate, and it can occur silently. And this can affect large blood vessels, so the blood vessels around the brain, the large arteries going up in the neck, around the heart, around the kidneys, and in the lower limbs, as well as the smaller blood vessels in our eyes, in our nerves, and also around our kidneys. All of these potentially can be damaged. And whether the blood vessels are the large ones around our heart and your abdomen, or whether they're tiny, fragile ones in the back of the eye, they all have a similar structure. And the way I describe it to people is that you can imagine the blood vessels being like the branches of a tree. The further you go away from the tree trunk, the smaller they become. But the smaller they become, they have an increased risk of being fragile. So that's one concept. The second concept is that the blood vessels all around the body, if you slice them in half and look down, they're simply like a hose pipe, so they're just a cylinder. Whether they're tiny, microscopic things, or whether they're large, kind of quite large tubes, the structure's the same. So they have muscle around the side, around the outside, that makes them contract or relax. And on the inside, you have a very thin membrane, and I describe that as a lining of cling film. And that cling film is meant to be nice and smooth. But things like high blood pressure, high salt content in your diet, high cholesterol, and high glucose levels, all over time can damage that cling film. And that cling film, if it gets damaged over a long period of time, increases the risk of that cling film leaking and causing damage. So that could be damage to the eyes, where blood vessels could leak, damage around the kidneys, where the kidneys can leak a little bit of protein, or major problems around the larger blood vessels around the heart or the brain, where it increases the risk of heart attacks, strokes, and also the risk of ulceration and lower limb amputation. So it can be very damaging to the body. We know that these exist, and so we want to make a plan as a country, as an NHS organisation, to make sure we can screen for that. Small vessels are known as microvessels, and as I've already described, this can occur in the eyes, the kidneys, it can affect men in terms of sexual health, it can affect the circulation in the feet and lead to problems. And again, for the larger blood vessels, these are known as macrovascular complications. They can lead to strokes, heart attacks, high blood pressure because of the kidneys, and also circulation problems in the legs. So it's really important that we do recognise that. And it's also important that we declare any concerns that we might have, whether it be our concentration, be it our vision, be it blood pressure problems, be it breathlessness, or any pain in our chest, any pain in our legs, or any problems with the skin in our feet. We declare that to any healthcare professional, whether it's your nurse, your GP, a dietitian, a hospital doctor, so that we can do something about it or investigate it, so we can nip it in the bud before it becomes a problem. I'm afraid I haven't been around the Diabetes UK little stands, but I'm sure they are available. Knowing what the rights are, I think, in terms of if we buy something from the shops, and knowing our rights as a consumer to say, I don't like this, I'm allowed my money back. You also have rights as a patient and as an individual with diabetes to know what's out there. And certainly, again, another plug for Diabetes UK is to say that they're trying to promote all the 15 essential healthcare checks and needs for people with be that type 1 diabetes or type 2 diabetes. And they range from just checks on your glucose level, checks on your blood pressure, checks on your blood fats, screening with photographs of your eyes, as well as also having the support there for any organisation that will help with your emotional needs and psychological needs, if need be, for anyone with diabetes. What I want to promote is, again, that same sort of thing, that if we detect a problem, we can do something about it. And knowing what's available is vital. We all know that we should go for our annual MOT for our car. We've got our personal MOT when it comes for diabetes care. So I hope everyone in this room that has diabetes has been for their annual MOT when it comes to photographs of their eyes, checks of their feet. Hands up. Way, that's a relief. Okay. Who hasn't? Next month. Okay, you're forgiven. Okay. So this is dead important. And I'm glad that there's a good system in place across Sunderland to try and promote that. And if there's a concern from yourselves or your families or your friends that who also have diabetes, that they slip through the net, tell somebody, because it's one of the most effective ways of nipping things in the bud so that we can capture any complications. And what we're trying to look for is essentially just doing the basics well. Checking somebody's blood pressure, taking photographs of their eyes, which are not nice, and the drops do sting and your eyes are blurred for a couple of hours. But the advantage is that we can detect the earliest sign of any complications, and if they are present, it doesn't mean it's going to lead to blindness. It means you might need other tablets to control blood pressure, control your diabetes, to control your cholesterol, but it's going to be reversible. And one thing that we found difficult across Sunderland is promoting the idea that each time you see your doctor or your nurse, provide a small urine specimen, ideally first one in the morning, but anything will do, and we'll send that to the laboratory and see if it has any protein in it. And by detecting simply that level, if somebody has protein in their blood, in their urine, then controlling their blood pressure a little bit tighter can reverse that, and that can significantly prevent any kidney damage. So, but knowing that you need to provide that sample is really, really important. And again, your foot checks to make sure that the pulses are there and that you can feel your feet are really, really vital. And by being able to feel your feet, you know that if there's a stone in your shoe, that you can stop, take your shoe off, get rid of that stone before it causes a problem with an ulcer. And these are just simple little photographs that you've probably already seen, where you have to rest your chin on a little rest and have some photographs done of your eyes. I don't suppose anyone needs a little photograph of a urine specimen or blood pressure, and what can happen with your feet. And this is actually a little prompt for me to warn people a few slides on. I do have some pictures of feet, so if you have a nervous disposition, or this is a government health warning. But before we get to feet, we'll get to kidneys. And again, I'm just going to re-emphasize what the structure of kidneys are when it comes to people like me. Well, before a little hazard. So thinking about the branches of your tree, the ones further away are very, like twigs, very small. The ones in your kidneys are your twigs. The other concept is that sort of chopping the blood vessel down the middle, and think of it like a hose pipe. On this side, we've got normal, and we have a very thin level of muscle, and the cling film is nice and smooth. That's normal, that's nice and healthy. But what can happen in people who have high blood pressure, high levels of glucose in their blood, high cholesterol, and kidney problems is that that blood vessel becomes thicker, the cling film lining becomes rough, and the hole in the middle is narrow by comparison. That's quite dramatic, and that happens throughout the whole kidney. And that's what leads to high blood pressure, which means more medication. That high blood pressure can lead to heart attacks. And that high blood pressure and damage to the cling film can also lead to the lack of ability for the kidneys to filter the blood, to get rid of the impurities in the blood. So that makes the individual person feel tired, run down, achy, and just quite nauseated. A horrible, horrible situation. But by detecting it early and providing that little urine specimen, we can prevent that from happening. And nationally, as well as locally, the number of people requiring things like dialysis or renal transplantation for diabetes is getting less and less, mainly because we're picking this up earlier, we're intervening earlier, and okay, people are taking more pills and potions, but we're making people feel better. So it's a really positive message. We measure kidney function and how well any one person's kidneys are working in terms of filtering the blood, holding on to the good stuff, and letting go of all the impurities by several methods. One is a simple blood test, where we measure something called a creatinine, and the normal range there is about 80 to about 110. The higher the number means the kidneys aren't working as effectively, and the normal range, obviously, your kidneys are working well. A second way of detecting how kidneys are working is making a mathematical calculation of how well the kidneys are filtering blood. And this is where we talk about the stages of kidney damage. Stage 1, which is normal, and it goes all the way down to 5, where it's called renal failure or kidney failure, and people sometimes are on dialysis for that. And it's divided between numbers of less than 15, which is dialysis, and above 90, which is normal. As we get older, it's natural for our bodies to change and our kidney function to change slightly and deteriorate, similar to how our skin changes. And so a number of people over the age of 60 or 70 will have a filtration rate around about 60 or thereabouts. And that's still healthy, but what we want to see is detect any change in the relative, as years go by. So that's a second method of detecting how the kidneys are functioning. The final method is obviously the urine specimen to see if there's any protein present within in the urine and what level that is looking like. And that's something known as the urine microalbumin. A normal level means your kidneys are healthy. And as that, if there is presence of presence of protein in the urine, then up to a point, we can start drugs that control people's blood pressure, and those drugs commonly can be drugs like lisinopril or ramipril, which bring down people's blood pressure and help with reversing that whole process. After a certain point, it may not be reversible, but we can prevent it deteriorating any further, again, by just giving you the same tablets. So a number of people, whether they have type 1 or type 2 diabetes, can be on a number of tablets to protect their kidneys, particularly if they've had diabetes for a number of years. And those tablets can be things like ACE inhibitors or ARBs. So drugs ending in pril or sartans can be quite commonly prescribed. And I commonly prescribe those types of drugs for people who might even have normal blood pressure, but to reduce their risk of having kidney-related damage or to reverse any protein that may be in their urine. So ultimately, in 10 or 20 years' time, we've averted any risk of kidney damage. But as people go on to more and more tablets, it becomes quite confusing and it becomes problematic. And I put this slide up just to emphasize that if anybody is on these tablets, water tablets, blood pressure tablets, or tablets for diabetes such as metformin, if there is, we all can suffer from vomiting illnesses or diarrhea, either because of dietary problems or just having a bad takeaway. It happens to us all. It's important that we stop those tablets to prevent our kidneys getting worse. And once we're better, we start those tablets again. And there's going to be little credit cards coming out for all people with diabetes over the next 6 months to try and promote the prevention of kidney damage if you have diabetes. Other tiny blood vessels, obviously the ones related to your eyes. I've got a bit of a cough as well. And again, that same principle where we're thinking about that, the branches of a tree and the twigs, and again, that sort of hosepipe kind of nature. The blood vessels in the back of our eyes are very fragile and are very delicate and are absolutely vital. But what we know from kind of surveys of people with diabetes is that we're all frightened about the possibility of losing our eyesight or having damage to our eyes. And that's why when we promoted the whole concept of having an MOT, it was all underpinned by making sure everyone got their photographs for their eyes done, because it is a worry, it is a concern. And by picking things up early, we can prevent complications occurring. And this is a list of what the potential concerns are when it comes to damage to the eyes. Normal is normal, which is nice and healthy. When you have your kind of MOT and your photographs done, you get a report back going to your GP, the hospital, and the practice. And it can either say it's normal, background retinopathy, something called pre-proliferative retinopathy, and proliferative. And up to a point, it's all reversible. Sometimes people develop proliferative retinopathy and they require laser treatment. But with careful control of diabetes, cholesterol and blood pressure, all of these are reversible. So it really is an amazing achievement with these drugs, with these the screening program, to make sure that we can pick things up early. And I've got some photographs now of what the changes can be. And if you picture, if you're looking at lace, the back of the eye, if it's damaged because of diabetes, can look like a lace pattern. And what you see is the photographs just down here, where you have tiny little loops of blood vessels which have leaked slightly. And that leaking is painless, it doesn't cause any discomfort, but it can affect people's vision when they try and look for long distances or for reading. And sometimes they also notice some floaters which impair a person's vision. And that sometimes, very sadly, can be the first time people know that there is a problem with their eyes. The picture at the top is to show you what the back of the eye looks like after it's been treated, where all those vessels have regressed after some laser treatment, and the little yellow dots there are the laser treatment points where it's burnt away those fragile blood vessels and prevented any bleeding at all to the eye. This is it in a bit of a close-up. I'll skip over the nasty photographs. Okay. Other things. One of my subspecialities within diabetes is to look after people and prevent foot problems. Statistically, very sadly, there's about 100 major amputations that occur in the UK for people with diabetes, and the worst thing about that is that 80% of that is preventable. And so, similar to the same way that the UK is trying to prevent diabetes occurring in the first place, we're also very keen to prevent eye problems, kidney problems, and foot problems, and hence the reason for that screening program to occur. And the risk can be for both people with type 1 and type 2 diabetes, and significant problems can occur. A little warning, the next few slides after that, there's a couple of gory slides, so but not too long. When we pitch up for screening, we want to look at both feet, we want to check our own feet, and there are some things that we can all do to make sure that our feet remain healthy and well. So we know that the podiatrists and the screeners will check the pulses to make sure the blood supply is good. They'll check the skin, they'll check for any evidence of hard skin or callus, and they'll try and take that away if there is a problem. And they'll also get the little monofilaments to see if you can feel and the nerves to your feet are working quite well. And they'll also look at your shoes to make sure you've got sensible, healthy footwear. So, healthy footwear, ta-da! Oh, yeah. Okay, so dry skin. Dry skin is never a good sign, okay? So the way I describe this to people is that it's healthy for feet to sweat, okay? It's a good thing for feet to sweat because that sweating, all that sweat also contains a lubricant for the skin to keep it soft, moist, and it's very similar to shoe polish or dubbing for your walking boots. So it keeps the leather nice and soft. And for the ladies in the audience or the men in the audience, we don't know what ladies do, so they have moisturising cream. So moisturising cream is good stuff, okay? And I prescribe lots and lots of it and tell men to use more of it. You usually don't have to tell women. But it prevents all the hard skin build-up. Other bits that we do is to check that the nerves are working fine. So we can feel our feet and we can feel bits on our toes, etc. Then it means that we can feel the environment around our foot, our shoe, any stones, so that there's not going to be any damage from that. And a key thing really is never walk barefoot anywhere. And I always worry when my patients tell me they're about to go on holiday. And I always emphasize to them, never walk on hot sand with bare feet, particularly if you've had diabetes for a long time, because you can't feel your feet and you're made of tough stuff. and next thing you know, they've got blisters on their feet, and it's all a horrible situation, and entirely preventable. This is an example of people, how they test for the pulses in your feet. You can do that yourself. Sensible footwear. So men never check inside their shoes, and women wear too tight shoes. That's a gross, kind of a sexist statement. But if somebody can't feel their feet and their nerves are damaged, then they are at increased risk of developing foot-related problems, or ulcers. And this is why we can make sure that we can prevent this. And I end up prescribing shoes, bespoke shoes for people. So these are handcrafted, best shoes, and the cost doesn't matter, but they are quite expensive, but they are so important when it comes to preventing ulceration, and they're so important when it comes to preventing amputation. Unfortunately, they're not fashionable. That's the only downside. So, horrible picture. I see this on a day-to-day basis, and whether it's a big ulcer like the one on the bottom where everyone says that it looks horrible and painful, or whether it's a tiny little break in the skin, both are just as equally as important to me, because both can progress, infection can get in, and it can lead to a whole world of trouble that could have been prevented if we caught it early. So if you do have a break in your skin, or you know people that aren't wearing the right footwear, or aren't turning up for their screening program, then we need to make sure that we tell them to turn up, because it's all preventable. Another plug for Diabetes UK. What we're issuing now is to say that we're kind of giving patients passports. So if somebody is known to have a problem with their foot, or have had an ulcer in the past, we'll be giving them a little passport, a little red card, not as a red card to get off the football pitch, but a red card to say, open all doors, this is a high-risk person coming through the doors, and we look after their feet. Very similar to the methodology for people who sometimes take warfarin, a blood thinning tablet, and everyone knows what warfarin booklets look like, and the same principle we're trying with foot attacks, so that we can prevent problems ever occurring. We're also issuing little patient information leaflets, whether it's eye problems, kidney problems, or foot problems. There's always an information leaflet to go with it, but and there's do's and don'ts. So I'm going to concentrate on the don'ts. So don't wear ill-fitting shoes. Okay, so things that are tight, ladies, if you're cramming your feet into tight footwear, this is going to be a bad thing, because the toes get rammed into, and you end up with a lot of friction. If you have a blister, don't burst it, okay? Get yourself to somebody who knows what they're doing, because if you burst it yourself, infection could get in. Hot water bottles. I know we're moving into supposedly summer, but hot water bottles, again, because of the heat associated with it, can damage the skin and lead to ulceration. And no DIY. If you have diabetes, don't give it a go yourself. Get a man in or a woman in. Okay? This is absolutely vital. And again, do not walk barefoot anywhere, around the home, on sand, outdoors, because the risk is that there'll be stuff on the carpet, stuff on the ground, hot sand, and it'll damage your skin and it'll damage your foot. You're going to get fed up with me about all the plugs for Diabetes UK, but does everyone have access to the internet? Quite a few. Does somebody know somebody who has access to the internet? So the Diabetes website, Diabetes UK website, has lots and lots of free leaflets, advice, and if you're ozone friendly and carbon friendly, you won't print it, and you just read it. But they have self-help management leaflets about the 10 steps to keeping healthy feet, as well as looking after your eyes and your kidneys and your heart and your blood pressure. There's a leaflet to go with it, which is brilliant. one thing that, in terms of a complication related to diabetes, can be the nerve damage that can occur because of high blood glucose levels. Sometimes it occurs also in people who smoke and have diabetes, that you get electric shocks running down the leg, you get a burning sensation, a tingling sensation, and this is really, really horrible. It keeps people up at night, stops them from sleeping, and they find it really difficult to walk. So if you get any of those symptoms or know somebody who's had those symptoms, it can be diabetes related, and there's plenty of treatment to make people feel better. Part of the MOT process is just to ask people 3 simple questions. Are you experiencing any burning sensation in your hands or feet? Are you experiencing any stabbing or electric shock symptoms in your hands or feet? And finally, are you experiencing any stinging or prickling sensation in your hands or feet? And if you answer yes to any one of those 3 questions, we can provide you with another questionnaire to help us diagnose any diabetes-related problem that could affect the nerves. And there's lots of different types of medication that people can take to help reduce those symptoms, reverse those symptoms, and make people's lives a lot better. Sometimes there's there doesn't have to be a tablet, there's creams as well, and there's also different types of footwear to ease the discomfort. So quite a lot that can be done to make sure that people's lot in life is better. I mentioned a little while ago that what we're trying to do is prevent complications from occurring, and also how to prevent diabetes and how to prevent complications, and knowing what to expect when you see a doctor or a nurse or you're going for your MOT is just basically doing the basics well. And the basics really are what we already know. What assessment of your glucose level is like, what's your blood pressure, what's your cholesterol and your blood fats, making some tests for your kidney function, be that blood test and the vital urine test, whether somebody's smoking, and what somebody's weight is like, as well as their foot and eye checks. And by having all of those 9 important checks, we can then help you help yourselves address any concerns. If everything's perfect, that's great. Then you get a big pat on the back, and also it's important that you know the effort that you put in with your diet, with your diabetes, with all the other tablets that you have to take. You're reaping the benefit. It's not all hard work that's gone to vain, because all of those checks are perfectly normal. So it's a big pat on the back. And by going for these checks, it becomes really important that if there is a problem, we can address it. So those are your 9 key care processes that we always try to promote. Lovely, thank you. And what we're trying to do really is trying to avoid all the horrible complications that you see here. And the statistics are quite bad, nationally speaking. In Sunderland, we're one of the better areas across the country, despite where we are, despite what I told you about obesity and the kind of concerns about weight and weight management. Because people know what to expect, because they're engaged with their doctors, their nurses, their dietitians, and their podiatrists, we're helping to reduce all these complications, but also because there's better insulins, there's better tablets, and there's better treatments for blood pressure and cholesterol. We're getting more and more people addressing their concerns with diabetes and reducing their risk of complications. I'm going to skip through quite a lot, as you can see. And again, just to emphasize really those kind of 15 essential care checks, the 9 ones that I've already mentioned, several ones, and I say they're probably too small to read now, but there are some really important messages to take away when it comes to diabetes. One is that we're here to help. Secondly, there is lots to be able, from my perspective, from Joe's perspective, to help people both with type 1, and type 2 diabetes. And doing the basics well and addressing blood glucose control, addressing blood pressure, and reducing blood fats by pills and potions, as well as lifestyle changes, can really reduce the risk of complications and promote a good quality of life and a long, happy life for all people with diabetes. So thank you.